Have you ever been told that your pain, chronic pain that you've been suffering on, is psychosomatic? Or worse, you've been told it's all in your head. Other words for that is considered neuroplastic pain, central sensitization. And one of the reasons we're talking about this today is although you should know that the pain that you have is not all in your head, what's important to consider is that maybe the solution for it is not about the body so much. It's how the connection of the mind-body happens. And when you recognize that it's not that your body is so weak or fragile, that this is something that you can do, it's so helpful. So we're going to work on some questions that is, I can share with you what I've learned from people from pain reprocessing therapy or other people to give you an idea that maybe this is more of a brain-driven pain than the other, to give you back your agency. If you're joining for the first time, my name is Kento. I'm a physical therapist by trade, and I consider myself more of a mind-body physical therapist. And if you feel like this mind-body stuff resonates with you, I want you to know you're in the right place. So let me share with you this questionnaire. All right, so wanted to talk about these questions here that I wanted to share with you. And these are questions that I've learned from a training called pain reprocessing therapy. And that is one of the things that I do along with how to connect it to movement, etc. And if you want other things to look at, you can look at and communicate, look up Alan Gordon or Dr. Howard Schubiner, who are leaders of this therapy that I know of. And some of the things you ask for is to recognize how we can distinguish between brain-driven pain and physical or structural-driven pain, is collecting data, because that's such an important thing to do, because we don't want to just assume that everyone has neuroplastic pain or brain-driven pain. So it's really important to do due diligence for ourselves. So one of the common things that you may see is that people feel and experience symptoms despite no injury preceding them. So suddenly your back hurts even though there was no injury. So you suddenly start to hurt the next day and it's an issue. Or the pain endures way longer than the injury that should have been healed. So for example, a ankle sprain where the ligament should have healed in like at least 3 months or so, but you still feel the pain 3 months later. Or in today's society, if a doctor looks at your MRI, X-rays, or CT scans, and it just shows everything's normal or good, or you find these normal, abnormal findings, what that means is like wear and tear or herniated disc or bulging discs in the back or the neck. These are normal things that are there where people that have no pain in the neck or back, they have it. Or arthritis. There are many things that we put just a word into it and diagnosis to it, even though these are normal. So it's very good to consider these things are very poorly correlated with a cause of pain. Other things that you might notice are like symptoms are symmetrical patterns, or you notice the symptom just moving one place to the other. I have a client right now where it jumps from like the back to the left knee, to the right knee, to the left shoulder, to the right shoulder. And yeah, that's a good indication that it's a brain-driven pain. Or you have it on both sides. Other things are like you might have GI or bladder issues, like you tend to get stomach issues, etc., but you can't really find anything outside of it. The other things are inconsistencies, right? The pain or symptoms switches on and off. So like it's drastically different during the morning, like the morning it hurts a lot, but during the day it doesn't. Or during the day it hurts a lot, and at night it feels better. Structural injuries tend to be consistent. So like let's say for an ankle sprain is an easy one, when you step on it, it hurts, or when you move it, it hurts. And as the tissue starts to heal, it starts to feel less and less painful when they walk. So there's a consistency when it comes to structural pain, right? Or the symptom spreads or migrates. That is not typical for that structural damage pain. So this is where having a doctor or people that are trained to see that, which is really helpful, especially in an anatomical sense. Delayed onset of pain during and after exercises. It is pretty common in my world in physical therapy where the person has had chronic pain, and the key thing is to not be stuck in that fear avoidance cycle of pain, especially moving. So when they start to move the area that they're kind of scared about, they might not have the pain during, but they have pain after the exercises. So these are key components to look at. And I think I already said drastically different sensation, different times of the day. Other things to recognize are triggers. So symptoms can be on or off dramatically shift because of conditioned responses to innocuous stimulus like food, weather, time of day, stress, moderate activity, or fear. What that means is your symptoms dramatically shift that are unrelated to the structural issue. So if stress increases your pain a lot, this usually means that it's more of the brain saying, hey, this is a danger signal, instead of some form of thing actually happening there. So symptoms when it's stressful, or when you just imagine the activity, annoying family members, or even some people are so sure that if they do this activity, it hurts. What this does is the brain creates a predictable pattern, because brain is a predicting machine. So when you start to say, hey, I know this is going to happen at this time exactly, these are things that will be considered triggers that we started to associate within the brain. Now, bonuses are something I already said here: visualization, delayed pains. But the bonus I want to talk about here is the common personality traits. There people that have been like perfectionistic, OCD, very conscientious, people-pleasing, anxiousness. These are common things that you'll notice that are common here, where if they are not perfect, they feel like they can't, it's dangerous. So these are people that tend to have, myself included by the way, increase in danger signal, which could be more susceptible to things like this. And I want you to know this is more common than you think. You are not alone on this process here. And for people that have difficulty also feeling emotions or expressing or sensing emotions, these are big ones as well. So why is this important for me to share to you on this one? Is one thing, when it comes to getting better with chronic pain, helping you feel safer and safer is an important aspect. It doesn't mean it's going to be comfortable. Like safety doesn't always mean it's like, oh, I'm just safe and I'm relaxing all the time. But it's to help you know that your symptoms are not as dangerous. There's not a structural problem. So one of the ways to do it is to you just continue to collect data for yourself and say, hey, right, like when I lift groceries that are 30 pounds, but when I lift a 5-pound weight that says the 5 number there, it's worse. Like you start to see the inconsistencies in how your tissues are responding or your brain's responding. So by collecting evidence, you start to collect and create this individualized understanding of, hey, I am safe. So this is such an important thing. So, hold on. So thank you for watching. If this information and how this resonates with you, you can contact me and email me at Kento@KamiyamaPT.com. I may not get back to you immediately, but I do my best to look at it and read it and then figure out from there.